thing, or eye being so long, and the further back I have to go, the more the energy sort of drops off and the view is worse. And so I do see some cluster of stuff that I think is that bigger one that you're describing. So we have to, yeah, so that's not delivering much. That's a little better. Not much.
My eye is long.
Yeah, people who are nearsighted have longer eyeballs front to back. And that's maybe part of the reason that they had floater problems. No. There we go. Now we're talking. That's a big mama. So, the retina's way back there. The lens is right here, so it's about mid-position. And what you can't see is that it's kind of part of a membrane. Maybe see little bits of that in the membrane. That's a part of there. And then my focusing beams. So I've got that lined up there, and we're going to make it dance a little bit there. There's the ring. Kind of opened up a little bit. There you go. And it's pretty dense, kind of resistant to treatment at first, so kind of at first it doesn't look like much is happening. As you kind of soften it up a little bit, break it down a little bit. Absorb the laser energy pretty well. And as we hit these things, you'll often see some little bubbles coming off, and those are the gas bubbles. Okay, it's drifting back a little. Let's see if we can move it forward a little bit. Let me have you look down, and then back to light here. And it's a little better. Breaking up, thinning, breaking up here. It's doing pretty good. Well, some of the little ones, if they're small enough, they won't cast a shadow in the retina and you won't see them. The big one is gone, definitively, and we'll have another chance to do a little tidying up in a day or so. Yeah, there we go. It's funny how just the very slight little changes to the position of the lens, or slight little change to angle, will take from nothing to a pretty good burst.
Most of us would think of a laser like what we're familiar with, where you have a laser pointer, we'll say, and you have the red beam or whatever color beam it comes out just as straight, and it just goes and goes and goes and goes. Skinny little beam that goes forever. That's how most lasers are, sort of typically designed. The YAG laser that I use is different, because the problem with using a skinny little beam of light would be like if you're trying to go after a target here, and it's moving, or the eye moves, or whatever, and if you miss, well, then that laser will go on to the next structure, which would be the retina, and deliver energy to the retina, which we don't want to do. So one of the cool things that they've done when they designed this is the laser instead has a cone-shaped energy profile to it, and that's an invisible energy that I can't see. So the way that I know how it's focused is there's two red beams, one that runs along the bottom, and one that runs along the top. And these are not this is not treatment energy. It's just light, light, so I can see. And where that light coincides tells me where the energy is going to be delivered. So there's actually a point in space where that energy is delivered. And the eye is relatively stable in the setup here. I'm actually moving the laser and moving that cone, so I can deliver that laser energy wherever I want. Generally, the sweet spot is kind of right in here. I can push that out further, but I can't work too close to the retina. The reason is that, well, even though the laser energy is focused to a very small point, 8 or 9 microns or so, there's a little bundle of energy, there's a little shock wave that kind of surrounds that. So I have to keep a kind of a safety margin away from the retina and away from the lens, which means I can treat here, and I can treat here and here, but I can't treat these floaters that are very typical of younger patients, especially I'll see guys in their 20s, maybe early 30s or so. Sometimes they'll have some very, very bothersome but microscopic little floaters, down here or so. So I just can't treat that stuff. Ideally, kind of treating in the sweet spot zone right there. That's where the energy is best, the focus is best. It's safely away from the retina.
You were saying what causes floaters. You're saying there's not really been much scientific research about it, but one of the things is nearsightedness that could cause it.
That's true.
Okay.
Or, they kind of get into cause, and in science there is, correlation does not mean causation. Correlation just means there's this and we associate it with that. So in the issue of floaters, we know that age is strongly correlated. In other words, most of the patients that I see are older, and they have more widespread degenerative breakdowns of the vitreous and more floaters, so age for sure. That doesn't explain when younger people come in their 20s and 30s with floaters. We can't blame it on age. What else? Well, people who are very nearsighted, they typically have larger or longer eyeballs, and they just, the floaters we see in them occur, they're worse and they occur at a younger age. So there is that association as well. And then there's other stuff that we just don't know. The reality is that my colleagues, my smarter colleagues who do research and academics, they're really not interested in floaters. It's not considered to be a problem, so why go looking for a fix to something that's not a problem? If you go back to my books and my texts and the journals and the conferences and all that, nobody talks about floaters. Just not interesting. And so you have a condition that affects a large group of people and nobody's really researching it. So, I'm unusual in the sense that my entire medical practice, my surgical specialty practice is treating floaters, but I'll be the first to admit I don't have all the answers.
Yeah, and how many specialists are out there that specialize the way you do in depth like this with the amount of experience that you have in treating floaters?
I'm not the first one to do this. There was a doctor in Florida, Dr. Geller, who has been doing this longer than I have. In fact, he was the first one in the United States. He actually treated another doctor in Virginia, Dr. Karakoff. Both of them have been doing this longer than I have, but they do their treatments as part of a general ophthalmology practice. So sort of that typical practice where you walk in, you've got a bunch of people waiting, and the gals behind the glass windows, and the extra rooms in the back. So they do their treatments as part of that. I can say with confidence that I'm the only one who has a practice exclusively dedicated to treating floaters. So I don't think there's anybody who does quite what I do. There's been a little bit of a change in the market where the company that makes my laser is now promoting the laser as a floater treatment laser. I have a bit of a problem with that because it's not the laser that's treating the floaters, it's the doctor. So if somebody buys their laser, they get listed on the manufacturer's floater doctor finder website, whatever it is. And so now that there's a couple hundred worldwide who are listed as floater treatment doctors, but I know that they don't have that much experience. So it's kind of a loaded question. I'd say there's just a handful worldwide who do a fair amount of this. I'm certainly one of them. And a lot of people who are kind of dabbling. From a business and competitive standpoint, I'm really not all that worried about them because I think what will happen is they'll try it, they'll realize that this is a lot harder and not quite as simple as they've been sort of led on to believe.
Yeah, so you have 9 years of experience with this, and that experience tells you how to use the laser and not damage the retina, and how to really, these are tricky things that the average doctor, just because he's an ophthalmologist and has a laser, wouldn't know, right?
Right, and also the laser. This is not a one-off specialty prototype that I made down in my laboratory. This is a ubiquitous off-the-shelf laser that most doctors have. It's called the YAG laser, and it's used to treat some conditions that occur after successful cataract surgery. One of the little membranes will get kind of cloudy, so you use the laser to break that stuff up there. So many doctors have the laser. But the professional and surgical skills that they have just generally don't translate well to treating floaters. So it is really something where you need to put in, I believe, your Malcolm Gladwellian 10,000 hours or so to really get good at something. And it's no different from any other skill. If you decided you wanted to learn how to play golf, if you had enough money, you could get Tiger Woods to teach you how to play golf, and he could teach you some basics. But what he can't substitute for is the thousands of hours of hitting a golf ball, and same thing with tennis with Serena Williams or whatever. You just have to put in your time and put in that. And I was fortunate to have sort of stumbled into creating this practice and doing it exclusively, so I was able to really get a lot of treatments under my belt. And the reality is, though, I will argue that it is a safe procedure in the hands of somebody who has a lot of experience, but it is a really difficult procedure. I'm still humbled every day that I come to work with, like the patient who was just here before.
And I looked in there and I did my evaluation. I'm like, I can treat this. It doesn't look too bad. And once I got in with better magnification and moving things around, I kind of realized that it's actually a lot more extensive than I thought. So I'm oftentimes humbled by, even though I'm very good at what I do, you can still sort of underestimate the complexity, and things are sometimes more difficult than you think.
So, as far as nutrition and the idea that somehow supplements or vitamins can help ameliorate the floaters, so what do you have to say about that?
I'm reminded of a quote that says that we should keep our minds open, but not so much that our brains fall out.
Right.
I love that one. I think it's Richard Dawkins, I believe. But
Carl Sagan.
is it Sagan?
That's
Very
what
good.
I heard.
Yeah, I love that one. But anyways, that is kind of a preface to there's a lot we don't know. The vitreous space where the floaters reside is a fairly inert space. There's no living, breathing cells, there's no blood vessels, there's no nerve endings, there's no immune activity. It's really mostly water. And there's also this thing called the blood-brain barrier, or the retina-vitreous barrier. So larger molecules like medications, proteins, supplements, things like that really should not be getting into the vitreous. And even if they did, there's no cells to sort of respond to that. There's no living, breathing cells that would take in that nutrition and behave differently or activate proteins. So I have a sort of a simpler mechanistic sort of approach to it, which is these protein strands, which are normally dispersed, about 1% of that volume, are naturally sticky, but you're kind of born with a non-stick coating on those protein strands, so they kind of mind their own business and stay away from each other. What we don't know is what changes over time, typically with age. But when younger people get floaters, what is it? Is it nutrition? Is it something they've done, something they haven't done? Is it in the environment? We don't know. But something might be changing to where these proteins get kind of sticky and they kind of clump up and clump up. And when they do so, then you have something more substantial and denser, where when light enters that eye, these things can now cast a shadow onto the retina, which is what you see when you see floaters. They're shadows. So we don't know. We know that people who are very nearsighted are more likely to have these floaters. Trauma can certainly do it. And anecdotes, a little bit here and there. There are people who said, I had this thing done, or I took this thing, and I developed my floaters. I just had a gentleman 2 patients back earlier today who just swears that this happened after he took ciprofloxacin, an antibiotic. I can't refute that. I can't necessarily say absolutely, but then on the other hand, I can't absolutely say that isn't the case. And the discussion we had with that is, well, if that's the case, and he went back to his doctor and said, hey, I was taking Cipro, and I developed these floaters, generally the doctor's attitude will be just to discount that and not make much of that, because again, if the doctor doesn't see it as a problem, it's not going to be reportable, and the information is not going to get back to the FDA, and it's not going to get back to the pharmaceutical industry. So these floaters are what I call the bastard diagnosis of ophthalmology. It's like, a lot of people have them or know about them, but they don't get the love and attention that cataracts and macular degeneration and glaucoma. So it becomes this thing that people have that nobody is really paying much attention to. And out of their desperation, many of them find me.
The blood-brain barrier really blocks the molecules and all the supposedly healing substances that would come from taking supplements or whatever.
I suppose, healing, you'd have to sort of say, what is the pathology here? Here's another way I kind of look at it is, and this, again, I have these simple models here. Let's say you had some fly paper strips hanging from the ceiling, and they're several inches apart. The room is quiet and they're just hanging there, no big deal. But you open a door, the wind blows through, and these things sort of stick to each other. Well, their local sticky forces are greater than any tendency for it to just sort of fall up. Gravity is not going to pull them apart. The wind is not going to pull them apart. I think that local stickiness there. Is that something that needs to be healed? I don't know. I kind of have a bigger picture look at it. It's like, in a way, it's really not pathology. This is not an eye health problem. You can have all kinds of floaters, and it can be disastrous in the vitreous, but the eye doesn't care. The eye's function is to take the information that's falling on the retina and transform that into nerve energy, send it through the optic nerve, and the brain is trying to make sense of the world out there. Now, the brain, you may not like the floaters. You may not like things swirling around and dancing around there. The eye doesn't care. So it's really, in many ways, it's still not an eye health problem. And so when you say, is there something you can take to heal this? Maybe again, it kind of goes more toward, is there something we can do to unstick those proteins or break them down? And there are some enzymes that can break down the collagen. Unfortunately, it's very nonspecific. So if you have a younger person with just a little bitty floater there, you put that enzyme in there, it's going to break down the vitreous and actually make it worse rather than better. So we haven't really found a good sort of pharmaceutical approach to it. And until maybe the industry and people with deeper pockets than me are able to sponsor some studies and maybe look into it a little bit further, we're kind of stuck with, I shrug my shoulders. I do a lot of shoulder shrugging, virtual and real. And people say, well, I this happened to me and then I got my floaters. Do you think that happened? And I'm like, I don't know. I'll be honest with it. I don't have all the answers to everything. I'm kind of a one-trick pony. I have a laser. It's what I use. And I don't have to be the smartest guy in the room. I may not be right now, but I'm pretty good at the laser. And part of being good is also knowing what not to treat. So going back to your question about this sort of blood-brain retinal vitreous barrier, if somebody has a significant infection inside the eye, or even with like auto-inflammatory, there's inflammation conditions that occur in the eye, well, you need to treat that. One of the reasons we can't treat an infection in the eye with oral or even IV antibiotics is that barrier prevents these molecules from getting inside the vitreous. So you actually have to do an injection right into the eye to get those medicines where you want. And this is why I'm a little bit leery of things that you can find on the internet, such as supplements or herbal therapy treatments or ancient Chinese medicine tricks or whatever. I'm a little bit suspect, and they tend to be sort of based on a little bit of pseudoscience and something that sounds kind of sciencey, or based on ancient Chinese medicine has been. I'm a little bit leery of that, and again, that's where I have to be a bit more of a scientist of this and say, you know what, I keep my mind open to it, but until you can actually show a good study that says that, I think then what's happening is it's a phenomenon when traditional medicine doesn't do something very well, and I'd say historically we haven't treated floaters very well, or at least not very many people doing it. It creates a vacuum and a void for people to go searching for something alternative that sounds kind of sciencey. And I've read the websites, and some of them sound pretty good. And it's going to increase the blood flow to the eye, and that will help drainage and help them filter out of the eye. And I'm like, that makes absolutely no sense. But it's kind of sciencey enough to lure somebody in to where they'll say, well, $80 for 2 or 3 months, I'll try it. I don't have that much to lose. And the company just made $200 or $300 or so. So
why does the blood flow and the drainage, why is that something that wouldn't work necessarily?
Because there is no drainage system for the vitreous.
Uh-huh.
There just isn't. No, you can take vasodilators and you can increase blood flow, and there are ways to do that. That's what people do for coronary arteries and things like that. So conceivably, you could possibly increase the blood flow, and that may actually be helpful for conditions like macular degeneration, which is really more of an intrinsic retina problem. But again, the vitreous is this privileged, isolated, inert, non-cellular, non-vascular, non-neural. It's just this sort of inert state there. So that's where I think the pseudoscience, it sounds a bit scammy when you understand the anatomy of the eye a little bit better. Yeah, there is a thing called a posterior vitreous detachment. And this goes not so much to being older, but this goes to where you might hear anecdotes of somebody saying, oh, I had floaters, and then they went away. I'm not so sure if they went away, but some of the small floaters that are closer to the retina, there is this correlation of the closer something is to the retina, generally the more distinct the shadow and the more bothersome it is. So if you have a small floater that starts off close to the retina and you see it and it bothers you, but then it moves a little bit further away, it hasn't gone away, but your awareness of it may have diminished and lessened. So I think that's a possibility.
And that happens because
the vitreous kind of shrinks and kind of pulls away. Yeah, especially with something that's called a posterior. Shrinks is not a great word, but a posterior vitreous detachment. It's really more of a shift of fluids, but there's sort of like an outer baggie or sac that can kind of pull away from the retina. So that's pretty common.
And does that happen with older people?
Yeah. In fact, if you were to randomly sample and truly random, a group of 60-year-olds, you find about 25% of them will have had a posterior vitreous detachment. If you go up to 80-year-olds, a good 60%. So it definitely is an age-related phenomenon. But that means that
a lot of 80-year-olds haven't had a posterior vitreous detachment either. So it's associated with age, but not necessarily going to occur as you get older.
So some older people will say, I had floaters, now they're gone, and that's
Right.
because of the post-vitreous detachment.
Right. And that might also apply to people when people have had younger people have had floaters for many years. The problem with younger patients is they typically have very microscopic little floaters sitting very, very close to the retina, and they may have seen floaters for years, and then if they have a posterior vitreous detachment without really any new floaters, that may have just sort of pulled those things away from the retina where they just are really not seen anymore. So when people say my floaters got better, I'm a little suspect that they probably didn't go away. They probably did get less bothersome though. I mean, I think that's more of an optical phenomenon rather than a filtration, clearing out, they actually went away sort of situation. So these are the reformer floaters. So it feels like in Terminator 2, when Arnold Schwarzenegger would take that gun and blast that metallic man, and that mercury would just kind of go all over the place, and then they'd just kind of reform. That's what it feels like. That's what it feels like treating the large diffuse cloudy floaters that I come across, and you blow those things apart, and you're thinking to yourself, the only thing I'm concerned about is a shoulder injury from patting myself on the back. I did such a good job. And then they come back a few days later with something reforms. But what reforms usually comes back as less. So I tell people in advance that the journey with those types of floaters feels like 2 or 3 or 4 steps forward and 1 or 2 steps back. 3 or 4 steps forward, 1 or 2 steps back. So there is this reformation that occurs with floaters. And by the way, what we didn't talk about earlier is, we're talking about treating floaters. I think it's really important to mention, especially if you have a younger audience, that in general, younger patients are typically not great candidates for treatment, primarily because they tend to have small microscopic filament floaters located very close to the retina where it's really not safe to treat. There are exceptions. Now and then I'll see somebody in their 20s or 30s who actually ends up being treatable. But it's all over my website. I'll tell people in advance, based on your age alone, I'll be glad to see you, but I have to really manage those expectations. I don't want this to come across as, I can treat anybody, come on in. I'm not trying to lure people in to get the consult fee. I really do try to manage people's expectations. The older you are, the more likely you're to be a candidate.
And these reform floaters, these Terminator floaters,
Yeah.
how often is it a situation where you get these reformers, like a percentage-wise?
Boy, it's a big percentage. The cloudier type of floaters are pretty common, and they're really, really oppressive, bad floaters, so it tends to draw people in from all over the world and all over the country. I'd say a good 50%, probably fair to say a good 50% are these floaters that do require a bit more treatment, a bit more work.
And you have people come in to visit you from all over the world, like what countries?
As far away as South Africa, Australia, Japan, Korea, China, Taiwan, all throughout the country here, scattered in Europe, Russia, Egypt, Scandinavia, not so much from South America, but that might be more of a function of Google searches depending on the language that you search in. Get a lot of inquiries from younger men in India for whatever reason. But yeah, all over. And that's not necessarily a testimony to how good I am, but I think it's really a testimony to how desperately people are searching to try to find a solution that their smart and very well qualified local doctors have just told them, got to learn to live with it. With the issue of the potential for elevated eye pressure, what I think is happening is we kind of look at the eye in two different compartments. The front of the eye secretes a fluid, it's called the aqueous. It kind of percolates into the front of the eye and then drains through what's called the angle here. It kind of drains and rejoins the bloodstream. It's doing this all the time. Produce, drain, produce, drain, produce, drain. And it's the balance of those two that determines the pressure of the eye. Okay? And every eye has a pressure. The eye likes to work within a range, generally 10 to 21 or so, something like that. Where I have seen the pressure go up, let's just reach for that, is when you're treating these generally kind of heavy, cloudy floaters towards the front part of the eye, and you're breaking that up, and ideally what I'm trying to do is definitively destroy that, convert that to gas bubbles, and it's gone. But these cloudier floaters are not as efficiently vaporized, and so you're left with a lot of microscopic protein debris. And that debris will do one of two things. It might either reform
a bit smaller than we started off with. That's not bad because you can go back and treat that. Or that debris might find its way into the front part of the eye and kind of gunk up and clog up the drainage system. So you're making the fluid, but it's not draining as well, and the pressure can go up. That's the problem. And so, you know, there really, most of the time, there really should be no elevation in pressure whatsoever. Even with aggressive treatments, it should just stay right where it is without much variation. Occasionally, a couple times a year, so 2 or 3 times a year, I'll have somebody that, you know, the pressures will go higher. And maybe in this zone, maybe it's not so bad, but I've actually seen pressures go much, much higher where I'm much more concerned. So that's why when somebody comes in with a moderately elevated pressure, okay, that's not so bad. We can sit on that and wait and let that pressure come back down to normal, maybe over the course of a couple months or so. But you know, you really probably shouldn't go in and treat aggressively on the remaining stuff, because that might just make the pressure problem worse and then get into a more dangerous
So it slips. What's this thing?
What is what?
This thing right here.
That's the lens. Yeah, that's the
so
natural.
It slips in.
It kind of goes in. It
between.
kind of goes in between here. Yeah, all this debris finds its way in between. Normally, the fluid is produced, and it all kind of stays to the front part here. It's produced, you know, percolates in this area here, and then and passes through this kind of passively exits through. It's called the trabecular meshwork, and it's just kind of a drainage system that brings it back into the bloodstream. So it's produced and drained all the time. It's constantly turning over in very small amounts. And normally it doesn't, you know, unlike, let's say, blood pressure, where, you know, stress or exercise and things like that will cause wide variations, usually it doesn't vary very much, you know, a couple points up or down maybe throughout the day, not very much. So, like I said, after treatment, I wouldn't expect the pressures to change very much. So when they do bump up higher, you know, that's a bit of a warning flag that maybe you either should not do more treatment or don't do aggressive treatments, and give it time for it to go back. Unfortunately, nobody's had, again, 2 or 3 patients a year, so nobody's had any permanent elevations of eye pressure, so that's not bad, but, you know, I don't want to make things worse either.
Okay.
So that's kind of the dilemma.